Okay, good morning. Yeah, what a bunch of wonderful faces. I'm lucky to be here because you've all been through a long journey, and I'm very honored that I get to talk to you. You're lucky too because it's 2017, and 20 years ago would have been a very different conference, right? There are many of you that have been here or talks like this several times, and others that are first-time comers. So there's the knowledge gap, and I think the people who have been here more will have tolerance for anyone who has a simple question or a question they feel, well, everybody would know the answer to. Ask your question. This is informal as a big lecture hall can be. I mean, if we were, I would rather in a small room, in a circular table, I think we would have a different conversation. But today, interrupt me, raise your hand. We have 2 hours. I'm really here for you. I've tried to make this presentation as broad and to answer as many possible questions as I'm able to. I may clearly miss something. So don't hesitate to ask me. If I know the answer, I will help you with that, okay? Just a little background. I'm a speaker for Alexion. I've been on their speaker bureau for, I think, 3 years now. And I've talked to pediatric groups, I've talked to adult groups, I've talked to mixed groups. I've been on the Global Genes speaker tour as well, so I've heard a lot of stories, and all of them are different. It always amazes me how people come to this diagnosis from across the country. I started out in New York on Long Island. You may hear it in my voice. I moved to Boston, and then now I'm in Houston, Texas. Sometimes I say Houston, not Houston. I don't know. Can't get the H in there. Houston. But from all the talks, I ask people to send me the questions they have. And so these are some of the ones that I've got in the past. And so I've included them in this talk. But there may be ones that are not on this list, and just ask away, okay? So you know, I think, basically that HUS is life-threatening. And it's a failure of the complement system. So we're going to go into what that means later. It damages all organs that are important to maintain life, right? Because people have been very sick. And the process by which it does so is something called TMA, or thrombotic microangiopathy, another process that we'll go through later in this talk. These are videos I've created to explain to you what the complement system is doing. So give me a little leeway here. I'm not a really good videographer. But that little is like a lightning bolt, and it essentially is looking for cells that may have markers that are damaged. And when it finds it, that cell is then taken away. So old cells, damaged cells, you know, if we didn't have that process, we would look really, really old. And as you age, actually, that process slows down, and unfortunately, you get wrinkles and other things. But that's called apoptosis, and it's an important process that the complement system is involved with. And the complement system is these little markers that help defend us, that's why I put the American flag there, from the attack of the complement cascade. So that's one function of the complement system. Now, I love to cook, and my husband doesn't, but I tell him, do not use my pans, because he uses the metal scraper, and guess what happens? He scraped the pan, and now it's ruined, right? So, and why is that? Because then all the food sticks to it. So you need to think about another part of what happens to the blood vessels as a damage to the cell, a scrape, and now things stick to it, cells, proteins, etc. And then what happens is you get a clot, a small clot in a small vessel, and then more and more of those small vessels get clogged, and that organ begins to die and not have function. And so that is called TMA, thrombotic microangiopathy. It's involving blood cells, platelets, white cells, all the cells that we know defend us. But it happens from an injury to an inside of a blood vessel. Thrombotic microangiopathy. The angio is the blood vessel. And complement is part of that process in calling those cells to the place of injury. So another aspect of this is, say I cut myself and I bled, and all of a sudden, I mean, it's just a nice clean paper cut. I see redness there. Why is that? It's because your coagulation system is intimately tied to the complement system. And that activation of the complement system is what the redness is. It said, help me, I need platelets, I need other cells to get involved with this cut. And so you'd say, great, but now we have to turn off that microphone that's asking for help. And how do we do that? We have regulators. And complement factor H, some of you may know what your genetic defect is, may have that, sits on the cell surface. This is my idea of what a cell surface looks like, a blood vessel. And it just is sitting there waiting. And then the activated complement system that was called, basically binds to this, and complement factor I, another common mutation that you might have, is also involved in inactivating the C3b so that it stops. So that's the brake on the system. These regulators attach to the active complement, they break them up, and it stops the process. Oh, you made my voice really loud. Okay. So now, what happens if you have a defect in complement factor H? Some people might actually be missing the complement factor H, and others have a defective one that it doesn't sit on the cell membrane anymore. And then what happens, the active in complement breaks a hole through the endothelial surface, and things rush in, and that's the end of that cell, because we need the barriers to protect these cells. So you need regulation of the complement system to stop it. And sometimes we're not really sure. People have the genetics, they're well, and others seem to bump into problems with maybe a surgery or a pregnancy, and this process becomes unregulated, and you get really sick. Is that, any questions on that? Does that make sense? Okay. Now, this is all the things, at least that we know right now, that can go wrong with complement. I simplified it for you. It gets pretty complicated. And that's why when I say I don't know the answer to your question, you'll understand that it's really complicated. And we don't have it. We just don't know. We are trying to, science, medicine, not just me, trying to figure this out. So in the past, the diagnosis was missed because the medical teams were not familiar. And my interest, and Sue knows this, and some others, that I missed the diagnosis in a baby. It was pre-eculizumab, but nevertheless, I mean, probably the outcome would have been the same because we wouldn't have been able to help her like that. But nevertheless, we thought it was the STEC or the E. coli-induced HUS. And now that I recognize signs and symptoms, I hope I will never miss it again. It also, these signs and symptoms look very similar. And as you mentioned, now that doctors understand it, they should recognize it. But the literature is filled with diagnoses of people who had TTP but didn't have TTP. Yes, Uncle John died and they didn't know why, but Uncle John may have had TTP and didn't get the right treatment. So even now, diagnosis can be missed. And I will tell you, recently, this month, a little baby came to our PICU, our intensive care unit, and she had been seen in an outside hospital, and she had sepsis. They call it cold shock, meaning she didn't have perfusion to her extremities. And the intensivist was taking care of her, gave her all the appropriate fluids and etc., vasosupportive agents. And the blood culture came back as strep pneumo from the outside hospital. In a 6-month-old, that's pretty unusual, but they treated her appropriately with antibiotics. She had kidney failure, she had multi-organ failure, she had blue extremities, and then she had TMA. And on day 5, they called us. 5 days in a hospital that I work at. I'm like a nut about this, right? And I went, oh my God, this is aHUS. And they only called us because the kidney function wasn't getting better. So, you know, the wheels go in motion. What day was it, Sue? Friday afternoon. And we were able to get eculizumab in 1 day, the Adams 13 in 2 days, and she had 2 seizures in between. Some neurological dysfunction, but the kidney function and the platelet count and things are getting better. But this was in my hospital that this was missed, right? And I'm like, oh my God, that's why we have to keep teaching. That's why you have to keep doing what you're doing. Because the intensivist just thought this was infectious TMA, and if he treated it, it would have gone better with antibiotics only. So now we also hear a lot of rumors. Like, for instance, in Europe, maybe 12 patients were treated with a kidney transplant and no eculizumab. That's really attractive, right? Like, wow, I don't need to be on drug anymore. But we don't know all their genetics. We don't know their history. And in each case, we still need more and more of good data to be able to conclude that that was a good plan. I'm all about safety in this because, you know, it's not like your hair loss was the issue. You know, I can get you a wig and you'll be fine. This is serious life-threatening disease, so we need to be really careful about the decisions and understand what the physicians are telling us that, okay, it's safe to come off. What does safe mean, right? So our understanding of this in many patients is incomplete. And if you know what this puzzle is, don't say it, because in the end I'll show you what the puzzle is. But we need to generate a complete picture to be able to generalize from one patient to another, to another, to another. As I said to you, you're all different right now. And so what would be good for you might not be good for you. And when we think of numbers, this is a rare disease, ultra-rare disease. We don't have a lot of power in some of the research that we have. So for instance, if I wanted to test a blood pressure medicine, I might use 10,000 patients and randomize them from one to another. And then I could say confidently that blood pressure medicine works. If I only have 100 patients, the power that statistically that I can say things confidently is not that good. Let's move, we'll go forward. So what drivers of complement activating conditions can start a TMA? In this room, we might have pregnancy, we could have GI illnesses. Just around the room, could somebody just, what started the problem for you? Do you know? You don't know? Birth controls, okay. A root canal. What? Stress? Oh, pregnancy? GI illness? Stress? In the back? I didn't hear. A hemo, okay. On this side? An illness? A virus? Flu. See, everyone's different. How about you? Illness, yeah. So infection is a big component. Surgery, autoantibodies, having children. For instance, I take care of an 18-year-old boy who they came from the hepatology group, the liver group. He has liver failure, and they didn't know why. So they sent him to me after they did a complete genetic test, and the only thing they found was a complement factor I mutation. So they said, does he have HUS? So I looked at him, I can't find any HUS. So I sent that the genetics were done for the whole array. We sent a smaller, more refined search, and now he has even more mutations, which the genetics group says, yes, he has atypical HUS. But he doesn't have findings of it yet. So that's part of the problem, right? Was his liver failure separate from this? Because he doesn't have any of this. And he doesn't have TMA, but he has the genes to develop atypical HUS. So we'll go through I'm going to bring that example back later. But when we look at most patients, 2/3 have had something activating their condition, and 20% don't seem to have had anything. They can't really explain what happened. Diarrhea, upper respiratory tract, and pregnancy is the most common. And then hypertension, which someone would say, which came first? We don't know. Transplant-associated inflammation of the kidney, a systemic disease, and cancer. It's less common, but still within 30%. So is something driving this or unmasking it? There's a difference. So, if I hit my finger with a hammer, that's the driver. It broke my finger, right? But unmasking it could be, like my brother had a pathological fracture that he had a weakness in the bone that broke. It was something that he did that unmasked it, but it didn't cause it. So we don't know if these agents are unmasking a silent complement defect or they're directly causing it. And so that we have a large knowledge gap in how complement contributes to each of these circles. And they include things that we just talked about: pregnancy, HELP, which is a postpartum or around delivery diagnosis, autoimmune disease like lupus, bone marrow transplant, surgery, vaccinations, infections, drugs, HIV. Actually, that was one of the first reasons they discovered TMA and atypical HUS, strep, and chemotherapy. But you'll notice this other big circle here with TTP. This is the E. coli atypical HUS. But TTP is a larger circle because it's more prevalent. We see it more often. Now, what other diseases look like atypical HUS? TTP does. And that's sometimes and still remains a problem because the signs and symptoms are identical. I'm going to bring you into current time period. A month ago, I got a call from one of my friend's son who runs a blood bank. And he was having to give a lot of blood product to this patient that was getting plasmapheresis. It was AB, a very uncommon one, and was very stressed about it. And he said, they think he has atypical HUS. I'm like, oh my goodness. So I started asking questions, and the gentleman had TTP diagnosed 10 years ago, lost his kidney function, had a kidney transplant, and now had TTP again. And the physicians didn't want to do any testing because he said, I know how to do this. So they had the nephrologist, that was the hematologist, they had the nephrologist write the orders for the tests. So even today, we have physicians that are just not open to this. They feel that they know what they can make this diagnosis. And you really need advocates sometimes to help you. So as you mentioned, it is a myth that only children get atypical HUS. And why, the literature was missing the adults 15 years ago? I think they all had TTP because I was trained that TTP was an adult disease and atypical HUS was a children's disease. Now, that was how we learned that the neurological involvement was TTP and not atypical HUS. So right there, the herd of zebras made a left and we were on the wrong path, right? So both adults and children, 50%, maybe depending on the city, could be more. And I think Sue said the oldest person she has now is 83. I had 82 before, right? That started with atypical HUS. So is it an active or chronic disease? I think this is a very interesting question. When we look at the pathology from biopsies, we see that there's signs of active involvement, meaning recent, versus others that there's a lot of chronicity or scarring. That would mean that something has taken time to develop as opposed to recently. Is it an active process, like I get a cold, and I'll get one every year, and I get better, and I'm back to my baseline, right? I haven't changed in any way. I got sick, and then I'm back to my baseline. Or is it more like an allergy where I have symptoms of allergy, but I'm always struggling with it. If I can encounter something, I'm just going to get right back there. So is HUS acute or smoldering? And I would say from even some of the people I've talked to in this room that there's both. They've had an acute event, maybe at the end of pregnancy, but nothing else. And others that sort of stuttered and stuttered and stuttered till somebody figured it out, right? And so there's evidence for both. We don't know. So, is there evidence that complement-mediated, and I think that's a term that may be changing atypical to complement-mediated, is a chronic and ongoing? Not for every patient, but eculizumab has dramatically changed the course, like it has for people with PNH. Does the presence of genetic mutations predispose to a more chronic disease? We don't know that answer. Does it mean that some patients can be withdrawn from therapy and some not? Probably yes. But who are you? And that's the part we have to figure out with certainty, not just, I think it is, I'm guessing that you're going to be the one. I need good data to be able to tell you that. So, systemic involvement, right? The central nervous system, up to 48%. This, we underline. I will tell you that little girl that came, the 6-month-old, she had the seizure and the ICU team immediately wanted to do a spinal tap. And because of that, they had to give her an infusion of platelets, which is the opposite of what you have to do for atypical HUS. You don't want to give a supply to the TMA to keep causing clots, but they did because they didn't want her to bleed from the spinal tap. Looking from one end of that picture, I could understand why they thought she could still have an undiagnosed illness that caused the seizure, but 50% have involvement. And clearly, when they did the MRI, they noticed that it was all consistent with TMA, not infection. And some of them, it can be simply confusion, stroke. The patient that I had lost her kidney function on the first episode. didn't recover and remained on dialysis. And then when she moved, she had a stroke 4 months later. Cardiovascular, 43%. Hypertension, peripheral gangrene, that's why I was telling you that that little girl had blue fingers. GI, 40%. Abdominal pain, gastroenteritis, nausea, vomiting. Visual. I've had 2 patients I've listened to who have had visual symptoms before they had any other sign. That was you? Can you tell us your story? Uh-huh. So important, they were to recognize that. Pulmonary, 46%. I would say that this is still a really difficult one for me. I had my fellow who I joke with him, I say he's drank the Kool-Aid, he gets it. At the cancer hospital where I work at, they do bone marrow transplants, and they had a patient that clearly met all the criteria for this, but the physician oncology team thought it was something else. And that patient died, so we don't know what it was, but he had pulmonary symptoms of pulmonary hemorrhage. And I guess I didn't put the kidney in there because the kidney is the most prevalent. And so you'd say to yourself, why? Why does a lot of the, or almost, let's say, the majority of patients seem to have kidney involvement? So you remember that video that I showed you that had the flags on it? Well, the kidney is missing most of the flags normally. So it can't regulate complement efficiently like other organs. The liver is filled with the flags. So the liver is the least involved of all the organs. So that's at least how we're thinking right now, that it's the amount of protection that you get from the regulators that is expressing some of this frequency, okay? But I could be wrong about that. But I like that explanation. Okay, the genetics. I don't know anybody in this room knows their family tree like this one, right? Amazes me that this one individual here did all this. But basically, it's very important to construct that because that's part of the information that your physician team needs to understand your risks. And oh, there it goes. Okay, so the complement system, just so that we'll underline it, it's really important in your immune system. It's a very elemental, ancient system that is responsive immediately to infection. It takes away dying cells and helps to keep your life a long and fruitful one. And it's balanced between removing cancer-type cells and bacteria and molds and parasites. So before the current decade, we had a limited understanding. Genetic advances have identified certain proteins and allowed, like eculizumab, targeted therapy. Gene mutations have been reported up to 60%, depending on the population. So in this room, how many have had genetic testing? How many have had the family tested? Okay. So, not everybody, right? Many of these mutations are in the heterozygotic state, which I think is another topic to think about, because many times a physician will get the genetic results and not really know what to do with it. They'll say, oh, well, this is a heterozygote mutation, can't be relevant. I'll explain a little bit in the next slide. But essentially, this is a very simplified version of what the complement pathway is. And I'm not going to make too much of a emphasis on this, other than there's an early phase and a terminal phase. And eculizumab, where is C5? There's C5, blocks right there. So this is the part, C5a, that's calling all the cells, come to this area, come fix this. And this is the C5b that punches holes in that endothelium, and these are regulators, MCP. I don't know if anyone has an MCP mutation, but factor H would sit on, etc. So gene history. This is basically a historical slide. 1973, the first complement gene was found, C3. And then when they mapped the human chromosome, we found a lot more. And now there's about 800 gene mutations on 800 mutations on about 12 genes that they've identified. And there are probably more that they'll find. Most of them have been discovered in the past 20 years. But still, 30%, 40% of patients don't know, they don't have an explanation. Oh, that's when the chromosome was mapped in 2003. Just to give you an idea, this is, like computer code. This is what factor H, the code for factor H is. It is very complicated. And what they're finding is there are sequences that seem to have more meaning on this particular gene if they're deleted than others. And if one end of the protein is misformed or has missense letters versus this, you can get a different disease. Even more complicated, right? So far, 315 mutations have been identified on this one particular protein. So when should genetic analysis be done? So the main caveat, and you underline it in yellow, whatever color you like, is that early treatment is important. You're not going to wait for genetics to do for this. You need treatment before you need genetic analysis. And if you never get genetic analysis and you have treatment, that's still a good plan. Ideally, we all want them, all patients to have genetic screening because we want to learn about this, right? That we want more numbers to increase the power of what we can say to patients. So who should have it? If you have complement-mediated atypical HUS is one of them. If you don't have any explanation for that TMA, if you have kidney function lost secondary to TMA, if you're getting a living-related kidney transplant, and if you're on therapy and you're thinking about coming off. I think that's an important one, and I have more to say about that later. So advancements. I probably am a little unusual in this. I don't think it's standard, but I have had patients that I've retested now. They had genetic analysis 5 years ago. So, and where I've done this, our center for some reason has a lot of families that come from Saudi Arabia that have, because of how families marry there, they have a lot of atypical HUS. And some of their genetic testing can be old. In fact, from Dr. Ramuzzi. So I've repeated it and found even more mutations, which are very interesting. So if I was thinking that maybe that particular patient didn't have enough to convince me because I wasn't there to see the atypical HUS, I redo it and I find that they have even more. So DNA sequencing now is not enough. Labs are looking at rearrangements, where the mutation is, and even copy numbers and functional processes of these genes. What does this mean to the protein if this is missing? So important to get testing in a competent biolab that looks at all the nuances and rearrangements. And Sue could help you with that. There's, if you were wondering, if where they sent the lab was okay. There's at least 6 in the country that we know of, right? And maybe David could help with that. Right, okay. So genetics, just briefly. Basically, we think of autosomal dominant in the middle. Your mother has it, she can give it to any of the children, and usually how it works is 50% can get it. Autosomal recessive, you need 2 copies, 1 from each parent, and 2 will be carriers, they won't have the disease, 1 will have the disease, and 1 child will not have anything. And then the other topic is autosomal dominant disease with incomplete penetrance. And I bring this up is because we think this is the mode of inheritance for atypical HUS. So that means that mom has the atypical HUS genes. She passes them to some of her children. She's had 4, maybe 2 of them. Do any of them have the disease? Somebody want to answer that question? Yes. Okay. But the answer is maybe they will and maybe they won't. This has to do with penetrance. So remember I told you about the patient I had who we sent the genetic analysis, the report comes back, yes, he has atypical HUS, but he doesn't have TMA. He doesn't. Penetrance is the 83-year-old that developed it, right? He went 82 years without any signs of disease. Some of you must have been in over 50 and you developed disease. That's penetrance. That means it's incomplete. 100% penetrance would mean all the children would show the disease right away. Incomplete means you might not. And that's what we don't understand, is what is going to reveal that in some cases and others not. Does that make sense? No? You're looking at me confused in the blue, the gray there. No, right there with the, you have the glasses on your head. Okay, yes. Yeah, so is there a rescue gene? Well, why not? I mean, as complicated as this is, why not? I don't know. So we see in patients, when I had one too, was a young man that came in and he had a drug toxicity and he developed over TMA, right? The small vessel clots. We took the drug away, he got better. So complement became unregulated, right? Spun out of control, but the brake went on as soon as so that we were thinking at that point that the drug was the driver. We took the driver away, he was able to control it. In other patients, they could have kept spinning, right? They don't have the regulators. Rescue gene, wow, I mean, we get so complicated on individual levels that, you do wonder how you can get up in the morning, I know. Right? But, this is the history of that little baby that came into the hospital. And I've gotten so excited about talking, I made him a boy, but it's actually a boy. So the pink circles are girls, the blue are boys, the X means death, and this means miscarriage. These are the genes, and this is twins. So that 6-month-old had a twin. Actually, the first twin got sick first. Twin A got a cold and gave the cold to twin B, who ended up in the hospital. Why didn't twin A have the problem? Well, you can see if they were di twins, there would be a connection here, but they're not. They're separate. They're paternal twins. So they're not identical. So maybe there's something different about twin A. But I actually wouldn't have been surprised if twin A had been identical, because still there could be things that are different. But look at the family history. We had a this would be great-grandmother who died at 56 years of a stroke. Is that unusual? I think so. Then we have grandfather that died at 88. That's okay. We have this baby died as an infant. You know, may have been other things, but I put like a little flag there. And we had this woman that had postpartum eclampsia and she died. That's a big flag. So genetic testing, genes found in that baby, here, here, and here. But these patients are well. So they didn't have it. And this is the conundrum that, you know, you're just like, oh, I want this figured out. How do we make this patient go back to this, right? What was the difference between this patient and that? I don't know. Yeah, so I'll emphasize here that incomplete penetrance of an autosomal dominant trait, not everyone expresses it. So we are missing something, and we need time to figure it out. I think that with time we're going to know. Very important, the risk of disease is affected by multiple genetic factors, which you inherited from your parents, and they don't have it. And as I showed you, the grandparents have it, but they are well. And we want to know why. So maybe it's the crosstalk between the coagulation system, the proteins that make you clot, and the complement, because we know they overlay like a computer chip. It's very important to determine, because if we can figure out what we are missing, as I said, we can bring back the patient who's sick to the state that the grandparents were in, that they're well. And right now we have eculizumab. Woohoo, that is wonderful, right? So that gives us time to be well and figure it out. And so research is moving to options based on drivers of disease on a personal level. That means, you know, your genes and how they function and how they regulate complement. Right now, about half of patients are genetically tested, and much less family members, as this room was an example of. Newer testing for complement is 12 genes, 800 plus mutations, and patients are generally not rescreened. So, importantly, a lack of history is not a negative history, but it's important to think back to your relatives for medical issues. In the group, can anyone say that they know that their family has had some signs or symptoms of? No? Okay, that's interesting. Have people really quizzed you about your family history? Shaken the tree? Yes? You said yes. No? I mean, I had gone to one Global Genes meeting where two of the siblings, they were in their 20s, had severe hypertension. To me, that's a flag. You know, severe 3-drug hypertension in a 20-year-old is unusual and should be investigated. I mean, it can be from different reasons. Not everything is aHUS, but if you have a patient with it and their family has it like that, you start to think. And I just put a little shake in there. So what if your genetic tests fail to find a complement gene abnormalities? Anyone here has had the test and no answer? Okay. About 30% do not have a gene abnormality, and it's difficult because no matter what we say, as human beings, we like to know there's a result. So I cannot tell you how many times I've given a talk and the doctor will say, the patient doesn't have a mutation, doesn't have disease. But as I just told you, 30% don't have the gene. They just fall into it like a mudslide. It's almost instinct. And I've also had parents say, oh, thank God you found it. as if it was something that they needed to know. It helped them to deal with what they were, the new diagnosis. I see shaking heads. You agree with that? Yeah. Because it's still a conundrum that this is a clinical diagnosis. We want the explanation, right? Yeah. We might know what's driving the disease. I mean, certainly I've read multiple reports in the literature. I've known a few patients that every time they're pregnant, they have a problem, and then when they're not pregnant, they don't. And yet, I knew one woman, this was her 4th pregnancy. She never got therapy. She kept, challenging herself with new pregnancy and died. But the playing field for patients with atypical HUS has changed. And while it's really a miracle, it has raised more questions, right? So we all want to know how to change our lifestyle and come off drug or not come off drug. What if your genetic test showed a variant of unknown significance? Anyone with that on their genetic screen? Okay, I've had a few from some of the patients that I tested. And so I have to call the genetic lab and I talk to them. I explain who my patient is and what happened to my patient. And they say, well, we've never seen that gene cause it. Okay, but it's in my patient, so now you have, right? So, I mean, basically, this is a statistical game. They want the frequency, how often they see this gene, to be very low, because then they feel that it's a reasonable estimate that it's causing disease. If they find it in everybody, they say, how can it cause it? Because everybody has it, right? So you move between suspected benign to suspected pathologic. So it can be difficult. So we're back to the drawing board. Challenges in diagnosing. Well, the symptoms and signs can be similar to other diseases. Did you see that? You gonna take a break? Okay. I'll back it up because I don't want to lose my Mini Cooper.